Okay, I think I'm recording. Yes. Okay, so when we talk about these chemical properties, this is what you check on the dipstick. So when you do that urine dipstick, each, chemical reaction is reacting to what chemicals are in the urine. I talked about pH, which, normal pH, which is called base, is 7.4. So again, if it's lower than 7.4, it's acidic urine. If it's above 7.4, it's alkaline urine. And typically, again, if an animal's an herbivore, a plant-based diet will create a more alkaline urine. Now, when you're an omnivore and a carnivore, omnivore eat both, and carnivores are primarily meat, which cats are our only true carnivore. Dogs are considered omnivores. But again, with these boutique diets, and sometimes people are like, I'm vegetarian, so I'm going to make my dog vegetarian. You may have to find out what the animal's eating, because that will influence the pH. Now, I talked about protein. Again, normally you usually want negative protein or trace protein. But again, if there's a high amount of cells in the urine, like if we have a urinary tract infection, cells in the urine will trigger protein on the dipstick. And also sometimes if an animal's on a high protein diet, or if they have high blood pressure. So again, we don't normally want to find protein on a urine, but if we do, then we got to kind of follow a path to figure out why is there protein, which is called proteinuria. So now glucose, normally that should be negative. We don't want to see positive glucose in the urine. There's some notes under here. Sometimes, if they're fearful and with restraint, obviously if an animal is on a dextrose drip, that could trigger a high amount of glucose, but sometimes you can get some false positives with these drugs. But one thing I want you guys to keep in mind, there's a glucose threshold. So when an animal has a glucose in the blood under 300, so, okay, let me back up. Normal glucose in the blood is like 80 to 120. So that's a normal glucose on blood work. If I have an animal that's hyperglycemic on blood work, when they get to about 300 in the blood, it starts to spill off into the urine. So to give you an idea, by the time you get glucose in the urine, we kind of suspect that the blood glucose is high. Now, if you're only doing a urinalysis, if you get a high glucose in the urine, you're probably going to need to back it up with a blood glucose to see, is it truly from, hyperglycemia, which is elevated glucose. So hypoglycemia is low blood glucose, hyperglycemia is high blood glucose. And then if you're too high in the blood, it's going to spill into the urine. So again, that's just kind of a way to determine if it's positive here and it's too high, then we're kind of suspecting that the blood might be too high. So it's a way to check. And the next thing we check is ketones. Now, ketones is another test that should be negative on a normal urine. But when we do see a positive ketone, when we got ketone, when we talk about what are things that cause ketosis, now some of you guys, if you were on that keto diet, people lose weight. Part of it is that the diet is causing you to burn fat and burn stores, and when you break down too much body fat, you can produce ketones. So we do look at what is the fat content in their meal. Are they breaking down too much fat? Is the patient been fasting or starving? Like now, if they're not eating for a period of time, the body is going to access what it needs. I've told you guys this before. It's like the body will break down its own stores. And if it's doing that, now if you have an animal that hasn't eaten for 3 or 4 days, and then you have positive ketones, that can be the body is breaking down its own stores. Cancer patients, really cachectic patients, and then it's basically deranged energy metabolism, meaning that the body is breaking down fat at too fast of a rate. Now, the other thing we look at ketones is if we have diabetic patients. So there is something called diabetic ketoacidosis, and I'm sure you talked about this in ClinMed 5, but if we have an animal, what's in ketoacidosis is they are breaking down their own body, and if they're producing ketones, that's a byproduct of this abnormal fat metabolism, abnormal energy metabolism. So again, we don't want ketones, we want it to be negative. But you know, when you think about a board exam, do they know that you understand the reason for every one of these tests on a dipstick? What are we doing it? Why are we doing it? What do we expect? What is it telling us? Now, bilirubin, again, this is not normally found in the urine. It should be negative on a normal urine. If we do have a positive bilirubin, you have to remember where bilirubin comes from. Now, the conjugated form, there's unconjugated and conjugated bilirubin. When we're testing for this, it's the conjugated. If you remember, in normal physiology, red blood cells die, and when a red blood cells die, the body reuses the hemoglobin, they reuse the iron, but they can't process the heme. The heme is sent to the liver from a dead red blood cell, and then heme, it's conjugated, and basically it's excreted through the bile duct into the intestine, and it becomes feces. Now remember, anything in the intestine, some of that gets reabsorbed back into the bloodstream. So when I see elevated bilirubin, you have to think, are red blood cells dying at too great a rate and the body can't process? It could be a liver problem, that your red blood cells are dying normally, but the liver isn't processing so an elevated bilirubin can have a few different reasons, but normally this is also going to influence the color. So now sometimes sunlight can break it down and you can get a false negative, but hopefully if the urine is in a room protected from sunlight or in the fridge, that's not going to be a problem. But now say somebody left the urine sample in their car and then it sat for a while in the sun, but hopefully someone protects it, sunlight protected, and we don't have that false positive. Now obviously you would do blood work to figure it out. Urobilinogen is typically, you can get small amounts, so negative to trace, but it can also come from hemolysis or liver disease, or there's a bile duct obstruction, where, it can prevent it from being excreted. But normally, urobilinogen, the thing that I would probably be looking at is, are there lysed red blood cells? So what happens is the red blood cells make it into the urine, maybe, into the bladder, and then they lyse while they're in the urine. So those chemicals from the red blood cell are released in the urine. Now let's talk about blood. Now blood is, most often when you find a positive blood, and this is what you guys will get practice with, either the urine is going to come out completely clear, but it's going to trigger a positive on the blood, or their urine is actually going to look bloody. It's going to look like there's hematuria, and then there's a positive blood. So when you look at your dipstick, there's hemolyzed blood and non-hemolyzed blood. Now, obviously, if we have hemolysis and you get that, it could be that there had been maybe blood and lysed cells, and then you're going to get the hemoglobinuria. But if you have fresh red blood cells that stay intact in the urine, then you have hematuria. So if you guys, like I said, a lot of times people do the dipsticks and you don't pay attention. But if you look at that dipstick, there's blood that'll show up as hemolyzed, which is like a hemoglobinuria. And then there is positive blood in the urine, and that's going to show up as hematuria. Okay, so there's two ways that we detect blood. Now, if you have hematuria, meaning the blood looks red, you see red blood cells, when you spin it down, you see that proof, You know, we think more urinary tract infection or something has caused irritation to the bladder. But again, if you have lysed red blood cells or hemoglobinuria, it means those red blood cells ruptured in the urine, and it can trigger a positive on the blood. So you got to, you know, review both. And then leukocyte, which is a white blood cell, you know, normal, we don't necessarily expect to see white blood cells in the urine. I know a lot of dipsticks will show positive leukocytes, which can tell you, and kind of but that sometimes on a dipstick, that can be a false positive. But what do white blood cells do? White blood cells typically respond to inflammation. Now, when you get a positive white blood cell on a urine, it's not going to tell you, oh, these are lymphocytes, oh, these are, you know, neutrophils. But, you know, neutrophils are your primary white blood cell that respond to, like Brittany said, fight infection, fight inflammation. So you can get an inflamed bladder. Like sometimes cats get what's called stress cystitis, where their bladder will get inflamed because the cat is stressed out. They don't necessarily have an infection, but the stress causes an inflammation in white blood cells. You know, what's a way that I can tell on a urine if I have positive white blood cells, if I'm talking about inflammation or infection? What else am I going to look at that's going to tell me? Is it infection or is it just inflammation from stress? Blood is usually present with an infection. If you've got a raging infection, bacteria, because if you've got white blood cells and then you see a whole lot of bacteria, then you know it's probably infection. If you've got white blood cells and no red blood cells and no bacteria, it could just be from inflammation. Now, I will tell you, 9 times out of 10, white blood cells go with bacteria, and we think of a standard UTI. But again, white blood cells can respond to inflammation from stress, and also, does your animal have a fever? Now, a lot of times an animal that has a urinary tract infection will be somewhat febrile. So you can go back to the physical exam and say, do I have any other indicators of inflammation? Which the first thing I'm going to think about is, you know, does the dog have a temperature? Or again, you could check your CBC. Do we have signs of overall white cell inflammation, which is going to also be an indicator. And then nitrites typically are another one that's negative, and we don't look at nitrites. I think a lot of these others are more important. But some bacteria, some UTIs, the bacteria will form the nitrite. So if you've got a population of bacteria and they're forming nitrites, it could be enough to trigger a positive. But again, I would say when I look at a dipstick, almost all the time the nitrite's negative. It would have to be a fair amount of bacteria to trigger that to be positive. Okay, so are there any questions about that? You know, I spend a lot of time talking about that, but I can't tell you how many urinalysis you do in practice, or even if you're not the one, even if you send it to the lab, when you get the urinalysis back, it's going to have all of those properties listed. You need to be able to interpret. Now, if you do a good urine, it should have a microscopic exam. Well, dipstick number 1 and specific gravity. And remember, when you do a specific gravity, you should use a refractometer. Your dipstick, a lot of dipsticks will give you a specific gravity, but the most accurate is to put it on a refractometer and get a specific gravity. And then you want to do a sediment exam. I love doing urines. When we do a urinalysis, now in the book, there's always obviously the gold standard. How many mils, like when I was in school, I was taught you should get to do a good sediment, you should have 12 mils of urine. But 5 to 10 is going to be accurate. But I'm going to tell you, in the real world, sometimes you only get a mil or 2. You know, sometimes the animal doesn't yield, or, you know, I told you guys you sometimes have to get it off the floor, which isn't ideal, but You know, if an animal pees on the table or pees in their carrier, that may be all you get. So 5 to 10 in ideal, and you should centrifuge it for about 3 to 5 minutes. You know, I'd say always go for the 5 minutes. And you want to do it on the low setting on your centrifuge. So you're not necessarily at your blood setting where you're spinning it. It sounds like the centrifuge is going to take off. Sometimes you turn on the centrifuge, I'm like, I wait a second. I'm like, because sometimes they migrate as they vibrate off the table. But this would be the low setting. We don't want to damage any of the components that are in the sediment, the cells, any crystals. So again, that's kind of why we're doing this at a lower setting. Now, stain is a lot of clinics will use SETI stain. Did you guys stain urines when you were in Clin Lab?
I believe so.
Okay, I mean, so in the real world, I mean, I prefer, I don't like stain on my urine, but if you were taught to use SETI stain, what you're gonna do is, you know, when you spin a urine tube and you pull it out, you're gonna have the stuff at top, which is called your supernatant. Now that's your fluid. Anything that is a component of like a cell, a crystal, debris, all those things are going to settle to the bottom. So what I used to do is pour out the majority of my fluid. I leave just a little bit. I would tap it on the counter to now you got to resuspend that sediment at the bottom of the tube. And then I would usually put it on the slide and put 1 drop of the SETI stain. Now, some people, like what it's saying here, is you can put the drop of SETI stain in the tube and mix it together. I've seen people do both. So, you know, for the test, it would probably be pour off your supernatant, put your drop of SETI stain, mix, and I don't know if that's maybe what you guys were taught. But you could, and what it's doing, it's going to stain. Now, it's not like doing a smear and like a blood smear. You're just putting a little bit of stain. But I would say in practice, you might see a lot of people, if you worked with me, I like to look at it without stain, but that's just, and sometimes a stain, always mix your stain. Sometimes they settle out. Sometimes there can be debris. So sometimes your stain can add artifact. So I just, you know, gotta be careful with that. So what are we going to look at? So the thing is, your low power, which is your 10x, is like when you put it on the slide, you want to look at low and kind of do like a survey and do a survey of the slide. And just look for like general population. Are there cells present? Are there crystals present? Are we seeing a lot of debris? So, and you're going to look for casts. Now, I will say sometimes, if you think about the urine, you'll sometimes get clusters of cells. Like you're not really going to have them spread out like a blood smear. That's where your cells should be separated. Sometimes they'll be in clumps, but you should still be able to identify what we're looking for. Now, when you go up to 40, now remember, you're not going to go to 100 because this is not a smear. You're not going to use oil immersion. You're only going to go up to 40. And at 40, then you can identify the cells present. Are there epithelial cells, red blood cells, white blood cells, or is there any evidence of bacteria? So that's when you're going to be able to identify. Now, sometimes the red blood cells, they're not going to look like they do on a smear, obviously. Sometimes the urine makes them crenate, where they get kind of shrunken in. Sometimes the red blood cells can swell if they've sat in too alkaline of urine. So, but again, remember just general sizes. A red blood a red blood cell is smaller than a white blood cell. So if you're having trouble discerning, a red blood cell should not be the same size as a white blood cell. So it's kind of a way to differentiate. And we tend to, AJ, stop. We tend to look in general if there's more than 2 to 3 white blood cells per HPF, which is per high powered field, that can indicate inflammation. Normally, when I do a urine, I might see per field, I might see no white blood cells or one here and there, which would be like occasional. OCC to 1 means you occasionally see one, and then, but if you can predictably go to different fields and see multiple white blood cells, then that's probably an indicator that there's an inflammation or bacteria. So there will be some pictures on the test. So, you know, these are what the white blood cells look like. And again, they're not going to look like a blood smear. So you're not going to see like the nucleus or the colors. Even if you put SETI stain, it's just going to help you highlight the cell. It's not going to really identify. Now, if you look at this little one down here, that's probably a red blood cell. And then this one that I'm pointing at, you can kind of see a nucleus there. So it's not that you can't completely, it's just you're not usually able to identify it. Now that little circle, that's nothing. That's probably air bubble. One thing I want to mention, is it on the slide? When I do urinalysis, I don't have my light really bright. You want to turn the condenser down so that I tend to look at it like it's a dim light. It's easier to identify. And also think of it, this is fluid. This isn't a smear. So sometimes you're going to have to raise your stage because you might be looking at layers. Now, if I'm an air bubble, I'm usually higher than a cell because a cell has more weight than an air bubble. So sometimes just moving your stage up and down. But usually, see how this is dim? Normally when you look at a smear, you want to turn up your condenser or open up the light versus dim it down. Now, if I go to this one, you can see white blood cell, and dang, I can see a nucleus, white blood cell. And then you can see over here, this is smaller, that's a red blood cell. So you can see how much bigger the white blood cell, and that's our RBC. And then you've got bacilli. Bacilli, which are your rods. So a bacilli is a rod, and then the cocci would be the circle. Now, a little tip, a lot of dogs, because there can be fecal contamination, sometimes you're going to see rods or bacilli more in a urine, and that can indicate kind of like potentially like a gram negative or like a kind of more serious infection. What you're seeing here is that's kind of reflective of a rod. It looks like it's bigger, but you're just on a different plane. But you've got white blood cell, that's a red blood cell, that's a red blood cell. Now this one is interesting. This would be kind of odd to have yeast. This could have been a free catch, but it's kind of rare to have budding yeast in a urine. This is a very strange urine sample. I've never seen anything like it, but you can see that's budding yeast. That's not a rod. That's not bacilli. Kind of looks like a shoe print, or I call it a headless snowman, whichever you want to do. Now this is a good picture because this is nice and broad, and this got a lot of different cells. So this is a really good picture to look at. You've got your white blood cells, okay? Look at this big cell. That's an epithelial cell. And again, the lining of the bladder is epithelium. The more inflammation that's present, the more epithelial cells. I don't expect a ton of epithelial cells if I did a cysto. You might see some if you do a free catch, and then you could potentially have a lot of epithelial cells if you do a catheter. Because if you think about, you drag that catheter up through the urethra, you're going to drag some epithelial cells. So now, if a dog has a raging UTI and they have a lot of bladder inflammation, they're going to shed more cells. So Lauren, it depends. You don't expect to see yeast in the urine, and it could be a different population. Now, normally I don't say it's this type of yeast, it's this type of, I would just say I saw yeast on the urine, which you might recatch, you might get a different sample to try and confirm. But, you know, if the dog has a yeast infection and it was a free catch, then maybe during the collection, the dog shed yeast. It'd be a similar population, you know, but different than what's in the ear, we would suspect. Now let's look at this slide. So you've got your white blood cells, and look at this little red blood cell, which sometimes they're a little more reflective. Epithelial cell, this looks like a piece of debris. It looks a little small to be a cast. And then you see these fat droplets. And all these little dots here are either air bubbles or fat droplets, but the fat tends to be a little more reflective. If it's an air bubble, it seems to have a really dark black circle. Okay, so you've got red blood cell, you've got an epithelial cell, some white blood cells, and see how some of these are clustered? You've got some that are spread out, and you've got some that are clustered. And here's some bacteria and some chunks of white blood cells. That's like a strip of bacteria. And then in this picture, and this is sometimes what you see if you've got a really strong infection, is look at these chunks of white blood cells. So so you can see the difference in size between a WBC and an RBC. So we got some differences, but a lot of times they will sometimes come off in chunks. This isn't too bad, but you can definitely see a white blood cell versus a red blood cell. So just more to look at. This is probably just debris. Now look at the shadows underneath. This is because the depth. So those are probably just artifact on the slide. It could be, debris. I mean, a lot of times I'll find a field and then I'll kind of go up and down through the field to make sure those aren't like cellular or casts or something significant. Now, these red blood cells, they're all kind of universal. You've got some white blood cells, these bigger ones, and these are RBCs. Sometimes they have this like crescent shape because if they've shrunk in, they can become concave. But most of the time you'll see them like where they're, dilated. And that's what they're showing. They can swell, or they can lyse. So you've got some here, look at like this one exploded, that one exploded, this one's kind of bent in half. This one's maybe a little, so different appearances. That's why, when I was in practice, I brought my lab. We had created a lab notebook when I was in school, and I had pictures, and I had, there's usually textbooks. If you're unsure, a lot of clinics will have posters by the microscopes. You can always look in your lab book. So always have something you can refer to. And so let's look at the types of epithelial cells that you see. Now, epithelial, remember, epi is lining. Epithelial cells line the bladder. They line the urethra. They line the tubules of the kidney. So you can see, squamous is what we see in the urethra. Transitional are seen in the bladder. And obviously renal comes from the kidney. So these are all types. Now, the most often cells that you're going to see are going to be the transitional epithelial cells from the bladder. But again, you could see squamous cells if they have enough inflammation or if it was a catheter. And then if they're shedding renal epithelial cells, there could be renal inflammation. Now think about it. If you've ever, urinary tract infections, if they start in the bladder, can migrate into the kidneys and cause a kidney infection on top of a bladder infection. So if you've got inflammation in the kidney and the bladder, you can get this mixed population of cells. And like right here, we've got, this is a squamous cell. So we've got that in the urethra, the vagina, and the vulva. So obviously if we have a free catch or a catheter, that you can get all these cells. They are large. And again, because they're on the upper lining, they tend to be flat and have a condensed nucleus. What's this these little snake things I'm pointing at right here? What's that? And this.
Is that a bacteria chain?
Yep, it's a chain of bacteria. So that's all you're looking at here. So you've got some cells, you've got some bacteria, some bacteria. So again, this is usually from either could be how you got the sample. And here's like what they would look like, you know, they almost look like see-through, flat, like cellophane with a nucleus, almost sometimes not a very significant nucleus. And here's a sample with SETI stain. So this is what a sample would look like. You can see the cell picked up the stain and the nucleus especially. Now what's interesting here is I'd have to look at some more, if this was a urine I was looking at, would some of these potentially be cocci? It's hard sometimes to determine, are these air bubbles? Now cocci would be, you know, very, very small. Here are some epithelial cells which are transitional. Now remember, a transitional epithelial cell, because the bladder, it's a mixture of populations of cells, you can see them in different, potentially different shapes. But, you know, these almost look like they have, not quite like a tail, but they're not going to have that big round, you know, these are the types of cells you guys also find on, like if you do an ear swab, a lot of times because you swab the ear, the inner lining of the ear is a squamous cell. It's the same type of cell. So you maybe say, gosh, that looks familiar. Also seen on ear swabs. Now this is a transitional cell. This is found in the bladder. So this wouldn't be something, you know, this should be from a urine. Let's look at a better, here's it. Now this is a urine that is not stained versus a stained urine with SETI stain. So you can see the difference. But look at how they're different because they're transitioning. Transitional epithelial cells. So sometimes you see them in different stages, but you've got a nucleus. Now that's a white blood cell that I'm pointing. This is kind of a neat right here. There's a red blood cell. There's a white blood cell. There's an transitional epithelial cell. So you can see the difference in sizes. And that should give you a clue. Looks like this one here looks like a squamous. It's got a little bit clearer, flatter, but these are your transitional cells. Now, this is hard to see. I've told you guys before, I remember telling you in anatomy, the common bladder cancer in dogs is called transitional cell carcinoma, or TCC, which is cancer of those cells in the bladder. Now, and when an animal has TCC, a lot of times there's a tumor growing in the bladder, and sometimes that tumor sheds these cells. What's different about this cell? Is there anything here that would make you think it's a cancerous type of cell?
It's multinucleated.
What?
It's multinucleated.
Yep. So you got binucleation. This is the nucleoli right here. So this is the that's a double nucleus. And then you've got a prominent nucleoli. Whenever you see a nucleus going through rapid changes, binucleated or prominent nucleoli, it's picking up quite a bit of stain. There's a lot of granular, which is the chromatin. That's an actively dividing cell. When you're seeing a lot of activity in the nucleus and the chromatin, can be an indicator of cancer. Now, that is not your job to find on a urine, but that could be a question on the board exam, is like, how do you know a cell is potentially cancerous? What are indicators of malignancy, which you should have gone over in Clin Lab 4? And you look at your nucleoli, you look at your nucleus, you look for mitosis, which is dividing, you look for active, granular chromatin. So the extremely large cells, so, sometimes when they're dividing, remember, cells are typically large when they're immature and they start to shrink. So sometimes when you have a population of larger cells, sometimes that can be, which is called macrocytosis, you've got those large cells that can be an indicator of malignancy. Again, I don't want you guys to think, if you see a urine sample with transitional cells, those are the lining of the bladder. If a dog has a straight up UTI, you're going to sometimes see transitional cells. Are those transitional cells malignant? Okay, so transitional cells in a urine does not mean the dog has TCC. So let's just make that clear. It can be sometimes picked up on a urine sample. Sometimes. Now, if a doctor saw that, we would probably do a biopsy or do what's called a traumatic catheterization and try to yield sheets of cells and send it to the lab, you know, obviously to make sure, or do an ultrasound of the bladder and try to take a biopsy, but, you know. And here are renal cells, which are sometimes difficult to determine. You know, if I looked at that, you might go like, okay, it's kind of close to a white blood cell. Now, here are some red blood cells. See how small they are? Those are red blood cells. This could be like a white blood cell. That looks like a white blood cell. And then these are bigger, but they're not quite transitional because look how nice and round they are. Okay, and a large nucleus. So the nucleus is larger. They are more round than a transitional cell. If you have a high amount of these present, it could indicate tubular damage, which we're talking about the PCT, the loop of Henle, or the DCT. Now, what would cause tubular damage? Could be an animal with extremely high blood pressure, an animal with kidney disease, or the animal has a kidney infection. Now, the other thing I'm looking at here is there could be some bacteria. This looks kind of like amorphous debris, which means I don't know what it is. It's just debris. You'd have to look at that. And then here's another picture. You can see they're just a little more round. Now this one is a little tipped, but wow. What are all these things in the background I'm looking at? Here, 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 here,
Bacteria.
here. Bacteria. If I'm seeing a lot of bacteria and you see a lot of renal cells, I'm kind of going, maybe this dog has a, you know, has a kidney infection on top of a bladder infection, because if you've got that much bacteria and a high yield of renal cells, that's an indicator of renal inflammation. Potentially that infection has migrated. And a lot of time, it'd be rare for an animal to have a renal infection without a UTI. It could happen, but a lot of times it's like chicken and egg. A lot of times the UTI comes first, it's undetected or it gets bad and it migrates to the kidney. That usually doesn't start in the kidney and go to the bladder. It's usually the flip side. So, any questions about those cells? Okay, let's talk about casts, which I think are sometimes a difficult thing to maybe bring up. But these tend to come from the distal and collecting tubules. So you've got the, you know, you've got the collecting duct. So remember your nephron. PCT, loop of Henle, DCT, which connects to the collecting tubules, empties into the medulla of the kidney, which goes out through the ureter to the bladder. So in these tubules, that's where you get your casts. That's where your casts come from. Now, it tends to, you know, what kind of cast is also how long is the filtrate spending in the tubules. Now, that is rate of urine production, which, you know, how often is the animal urinating? Does the animal have high blood pressure, which could cause pressure in those, in the nephron? So I'd want to know, does the animal have, you know, are we worried about high blood pressure? But how much damage is present? So let's look at the time. Now, they tend to dissolve when urine has sat, so that's another reason to refrigerate. Also, maybe in alkaline urine, sometimes they can dissolve. So again, it's always best when you are doing a urinalysis to either refrigerate it or try to do it as soon as possible so it is the most accurate. But we've got hyaline, granular, epithelial cast, leukocyte cast, waxy cast, fatty cast. Well, you know, an epithelial cast is probably going to be made of epithelial cells from the tubules, and a leukocyte cast is probably going to be made up of white blood cells. I'm just going to guess. Hyaline casts tend to be, you know, they kind of have this clear, it's kind of like there's just an outline. Now, that is not a parasite. It's not a worm. If it's coming from the urine, this is, and don't worry about that squiggly thing, that is not a parasite. But this would be hyaline, which is primarily made of protein, because protein makes tissue, and so part of that has broken away. May be just an indicator of some irritation, some inflammation to the kidney. Now, more often than not, probably the one I see the most are these granular casts. And they tend to look, you know, anytime you look at a cast, they're not always perfect. But that's a pretty decent tube. They kind of look tubular. You've got there's coarse granular casts and fine granular casts, but a lot of times on a urine sample, you're just going to call it a granular cast. Usually on your paper, it'll say casts, like yes or no, and then usually there's somewhere you can write the type of cast you think you saw. But this can sometimes happen. It's usually not an indicator of a huge problem, just sometimes they are shed and seen. Now, if you look at this, I got a whole lot of stuff in the background that I'm suspecting is bacteria. But again, the thing is you have to think about, these things are on different planes. So when you guys focus to look for cells, you're going to have to change your objective sometimes to look for casts, and then move to a new spot, check, move to a new spot, because they're not always going to be on the same, you know, there's a lot of significant stuff it looks like under here, but I'm just focused on this cast. And then you have epithelial casts, because it is in a, you know, in this form, but it's made up of epithelial cells. Now, again, this can be inflammation anytime, but this is epithelial cells from the tubules. This isn't from the bladder. If it was epithelial cells from the bladder or from the vulva or from the urethra, they'd be kind of like spread out like we were just looking at, but this is in the form of a cast, so therefore it came from the tubules, if that makes sense. And then sometimes you can see RBC casts, which again, sometimes they get in this formation from the tubules. Again, this could be an indicator that could be some bleeding in the kidney or inflammation. And then you get these waxy casts, which you can see this is in a form. It's not granular because it kind of looks almost see-through, but they do tend to reflect the light, so sometimes they kind of show up like shiny, and can just be, you know, got a little arrow here, have a little white blood cell hanging out. Maybe that's a red, no, I think that's a red blood cell. It's hard to tell. And then sometimes you get fatty casts, which, you know, is, you've got a cast form, so we know it came from the tubules, but they've got lipid droplets. And sometimes cats with renal disease can have these type of casts, disease to the kidneys, and, you know, the fat not where it needs to be. Okay, we're gonna have to move on to crystals, but I know we're about done. So are there any questions as far as this?